Hi, so we'll start the lecture. So today's topic is on surgical management of movement disorders, and we'll be covering this under two parts. The first part is particularly focused on Parkinson's disease. The second part will cover tremors and dystonia. So today's topic will be covered into three sections. The first is on patient selection criteria in Parkinson's, and then we'll cover the ablative procedures, and then finally DBS for Parkinson's disease. So, coming to patient selection criteria in PD and how we decide whether a patient is fit for surgery when it comes to PD or not. So, when it comes to patient selection for PD, it's important to get evaluation done under all the following topics. So, it's an evaluation by the neurologist, by the neurosurgeon, as well as by neuropsychology is necessary, and then followed by neuroimaging and medical clearance. So when it comes to the neurologist, the most important thing is to establish the correct diagnosis. DBS is only indicated for idiopathic Parkinson's disease. It does not work for other types of Parkinsonism. It's also important to establish that all other reasonable medical therapies have been tried and that they are not working very well right now. And it is also important to evaluate the patient both on and off medications. The neurosurgery team should go in and evaluate whether the patient is an appropriate candidate for surgery or not. So that's where you go in and define what is the risk-benefit ratio of the procedure, and also to explore potential contraindications to surgery. And we'll discuss what are these contraindications much later in the lecture. The neurocognition and psychiatry evaluation is done because in a lot of patients who are undergoing surgery for Parkinson's disease, they could already have early cognitive decline in PD. Also, it is possible that they can develop cognitive decline or other psychiatric symptoms after DBS. So it is important to define what patients already have before they undergo DBS. All patients undergoing DBS for PD need to undergo an MRI before surgery. And for a lot of these patients, it is important to stop vitamin E and aspirin at least 2 weeks before surgery before they undergo DBS. Now, with DBS and PD, the important selection criteria is that, as we discussed, it is important to make sure that the patient has idiopathic PD and also to rule out postural instability. Postural instability is actually a relative contraindication of PD. And if a patient has early postural instability, it could actually indicate the presence of atypical Parkinsonism rather than idiopathic PD. Apart from that, a disease duration of at least 5 years is required to establish that the patient has idiopathic Parkinson's disease. If the disease duration is for less than 5 years, it is possible that the patient might still have atypical Parkinsonism, and a disease duration of at least 5 years is required to establish that it is idiopathic and not atypical Parkinsonism. It has also been found with the early STIM trial that you can offer DBS quite early. So you can even offer it about 7 years after initial motor symptoms rather than waiting for a later time in their PD. Also, with disease severity, at least a UPDRS3 score of 30 or more is required to offer DBS. Another important aspect of patient selection criteria is that with levodopa, they should have marked motor fluctuations. So there are two main indications for DBS in PD. One of them is marked motor fluctuations, and the other one is refractory tremors. A very important predictor of response to DBS would be the response to levodopa. It is actually the best predictor of outcome after DBS. And if a patient responds well to levodopa, they're very likely to respond well to DBS as well. The most important thing here is to figure out if the gait difficulties do or do not respond to levodopa, particularly whether the freezing and imbalance in the off period responds to levodopa or not. There should be at least a minimum 30% improvement in the UPDRS3 score when the patient is on medication than when they're off. Right. Coming to target selection in patients with DBS, there are three main targets that we have to know about, the GPI, the STN, and the VIM thalamus. So the VIM thalamus is the most simple. The only thing you have to remember about the VIM thalamus, or the ventro-intermediate nucleus of the thalamus, is that it only provides tremor relief. It does not work on any other symptoms of PD, but it works very well for tremors. It is almost complete or near complete relief of tremor in almost all cases of tremor, but even for Parkinsonian tremor as well. Now, the two most important targets for PD are GPI and STN. So both of them are currently used, and both of them have advantages and disadvantages. So, in the GPI, we particularly want to target the sensory motor part of the GPI. And the sensory motor part of the GPI is the ventral, posterior, and lateral area of the GPI. So, targeting this region of the GPI is going to improve the three most important symptoms of PD: the tremor, rigidity, and bradykinesia. Another very important effect of targeting GPI is that it has a very good reduction of on medications or dopamine induced dyskinesias. And STN will not do that, but GPI will. But unlike STN, targeting the GPI does not reduce levodopa requirements. So, two important things to remember: that GPI will reduce dyskinesias caused by dopamine, but it will not reduce the levodopa requirements. STN, on the other hand, it will reduce dopamine requirements approximately 5 years after implantation, but it will not work on dyskinesias. But both STN and GPI are going to improve tremor, rigidity, and bradykinesia or akinesia in the off state. Again, GPI will reduce dopamine-induced dyskinesias, but not reduce dopamine requirements. But STN will reduce dopamine requirements, but not reduce dopamine-induced dyskinesias. Another newer and quite effective target is caudal zona inserter. So that is located quite close to STN, and it is comparable, if not superior, to STN DBS. But a problem with using the CZI is that there are worse adverse speech effects with the CZI than with STN DBS. It does have a very good effect on Parkinsonian tremor, and actually, it has got the highest reduction of Parkinsonian tremor as compared to any other target. Another target which has been considered for DBS in PD is pedunculopontine nucleus. As we have discussed in the previous seminar, it is considered predominantly for gait disturbances, but the current literature on the pedunculopontine nucleus is mixed, and currently it is not recommended at present. Right, so we'll discuss a few questions about this section. So which of the following is true? The Wim thalamus nucleus ablation or stimulation has the best results for PD tremor control. Pedunculopontine nucleus DBS is recommended for gait instability in Parkinson's disease. The best predictor of DBS for PD is response to levodopa. DBS is offered to patients with UPDRS 3 scores 20 or greater. You can leave the answers in the chat box. Right, so the answer is the best predictor of DBS for PD is response to levodopa. The other are all false. The best result for PD tremor control is actually with caudal zona inserter stimulation. PP and DBS is not recommended for gait instability with the current literature that we have for PP and DBS. DBS was offered to patients with UPDRS 3 scores of 30 or greater, not 20 or greater. So second question is, which of the following targets lead to the greatest reduction in dopamine requirements? GPI, STN, Wim thalamus, or PPN? So the answer is GPI. This again, this is where confusions can arise. The only two important targets in DBS are GPI and STN. GPI, I'm sorry, the answer is STN, not GPI. Yeah, so the STN is the only nucleus which, if you target, leads to greatest reduction in dopamine requirements. GPI DBS does not lead to reduction in dopamine requirements. It can reduce dopamine-induced dyskinesias, but it cannot reduce dopamine requirements. STN DBS, on the other hand, will reduce dopamine requirements. Wim thalamus and PPN DBS will have no effects on dopamine requirements. Right. So coming to the next section, that is ablative procedures for Parkinson's disease. So as compared to DBS, ablation has largely been supplanted. It's The fact is, at the end of the day, DBS is safer, and unlike ablation, it can be done bilaterally, taking care of symptoms on both sides. But DBS cannot be done for all patients for a lot of reasons, and so ablation is still considered for a few patients. Now, how ablation works, we have already discussed these pathways and the changes that happened in Parkinson's disease in the previous lecture. So just important things to recall, there is the indirect pathway, which is controlled by dopamine, and the important output of the basal ganglia at the end of the day is GPI and SNR, and an important nucleus in the indirect pathway is the STN. So what happens in Parkinson's disease is the indirect pathway is hyperactive because of a lack of dopamine. And because of that, the output coming out of the STN and the output coming out of the GPI SNR is going to be increased, because of which the inhibitory output overall of the basal ganglia has increased. And that is the pathology in Parkinson's disease. So if we ablate either the STN or the GPI SNR, this inhibitory output, which was increased in the Parkinson's disease pathway, should come down. Right. So with the pallidotomy, we predominantly target, as we have discussed, the posterior ventral part of the GPI, that is the sensory motor area of the GPI. And we try to avoid the limbic and the associative territories of the GPI. So these are to be spared. Apart from that, we would also like to avoid the GPE, the optic tract, and the internal capsule, which are all quite nearby. With a subthalamic nucleotomy, on the other hand, so there's a difference between what is a subthalamotomy and what is a subthalamic nucleotomy. So subthalamotomy is basically a lesioning of the thalamic afferent fibers, and they actually are the fibers coursing below the thalamus, and it is not the ablation of the subthalamic nucleus. So it is a subthalamic nucleotomy, which is a lesioning of the STN instead. The WIM thalamotomy, on the other hand, it targets the tremor cells located in the ventral intermediate nucleus of the thalamus. And as we have discussed multiple times, it has little or no impact on other features of PD. Right. So let's discuss as to when you would consider using a pallidotomy, a subthalamic nucleotomy, or a WIM thalamotomy instead. So with a pallidotomy, the predominant indications are for levodopa-induced dyskinesia. As we've seen, GPI stimulation or ablation works very, very well for levodopa-induced dyskinesias. Apart from that, you would also consider for patients who have severe wearing off on-off fluctuations, leading to rigidity, bradykinesia, and tremors, and even for patients who have off-period dystonias. So when it comes to GPI, two important things to remember are levodopa-induced dyskinesias and off-period dystonias. Pallidotomy is usually going to be done unilaterally, and the effects that happen of pallidotomy are going to be usually contralateral, but there will be like a very small amount of ipsilateral effects which can also occur. It is important that before you do a pallidotomy, always rule out other causes of Parkinson's disease, because Parkinson plus syndromes and atypical Parkinsonism will not benefit from these ablation procedures. A way to do that can be with FDG PET. It can help you differentiate PD from Parkinson plus syndrome. So on FDG PET, PD will have lentiform hypermetabolism, while Parkinson plus syndrome will demonstrate lentiform hypometabolism. Right. So a lot of patients with PD obviously have bilateral pathology. So it is important to remember that bilateral pallidotomy is to be avoided at all costs. There's a significant risk of impairment to speech, swallowing, cognition, and gait. So usually we try to preserve these ablation procedures for patients who have significant asymmetric symptoms, when they have usually like one-sided tremors or one-sided rigidity. That's where we usually try to target ablation to one side. Another possibility is for patients who have bilateral pathologies to target one side with stimulation and target the other side with ablation. Right. The other nucleus we can target with ablation is subthalamic nucleus. As we saw, there's a difference between subthalamic nucleotomy and a subthalamotomy. So currently with subthalamic nucleotomy, there are limited clinical studies only. Just like GPI ablation, it also reduces tremor, bradykinesia, and rigidity contralateral to the lesion. Also, as we have seen multiple times, with STN ablation, the dopaminergic medication requirements will come down, unlike with the pallidotomy. But unlike with the pallidotomy, it does not reduce on-state dyskinesias. Because it is a subthalamic nucleus at the end of the day, there is a risk of hemibalismus with ablation of the STN. But an important thing to remember is it is safer to perform an STN ablation bilaterally than to perform a GPI ablation bilaterally. The third nucleus that we can ablate is the Wim thalamus. So as we saw, it is a very good target for tremor control, but it works only for tremor control. It will not work for any other symptoms. So it is usually only indicated for patients who have PD with severe asymmetrical tremor that is unresponsive to dopamine. We want to avoid bilateral thalamotomies because just like GPI, it can cause adverse speech and balance effects. Right. So how do we go about doing this ablation at the end of the day? So there's a significant amount of planning which goes into this before the surgery itself, right? So an MRI has to be done preoperatively, following which, based on the MRI, the nucleus that has to be ablated is targeted. Now, there are two methods of targeting this nucleus. There's a direct targeting and there's an indirect targeting. Indirect targeting is what is most commonly used these days. It is based on the ACPC line, or the anterior commissure posterior commissure line, or the ICL, or that is the intercommissural line. And the direct targeting overall is currently growing, and it is now possible with your 3 Tesla MRIs, because now with these you can directly see the nucleus. The reason we do indirect targeting is with the current that MRI systems that we have in place, it's very difficult to directly point out where the nucleus may be, and that is why you have to use the ACPC line to define where the nucleus may be. Now the GPI target, based on this ACPC line at the mid-commissural point or the intercommissural line, is as follows. So it is not important to memorize these numbers. It's just they're there here for reference. So the GPI target is going to be 2 to 3 millimeter anterior to the MCP, 3 to 6 millimeter below the intercommissural line, and 20 to 21 millimeters lateral to the ACPC line. So the computer will just do all this work for you almost. STAIN, on the other hand, is also quite similar. So you take the MCP again, but instead of going 2 to 3 millimeter anterior, you have to go 2 to 3 millimeter posterior to the MCP. About a similar amount of distance below the ACPC line, but instead of 21 millimeter lateral, you only go 12 to 14 millimeter lateral. So it's quite similar, just almost in the opposite direction. So again, GPI is 2 to 3 millimeter anterior, about 4 to 6 millimeter below the ICL, but 21 millimeter lateral. While STAIN, on the other hand, is 2 to 3 millimeter posterior, 4 to 6 millimeter below the line, and like about 14 millimeter lateral to the ICL. Well, the Wim thalamus is slightly more complicated to get. So you draw the ACPC line, and then you mark out 25% of the distance of the ACPC line, and take that posterior to the mid-commissural point. At that point, you go about 11.5 millimeter lateral, and that is how you're going to target the Wim thalamus indirectly. Right, so it's not important to memorize those numbers. The computer is just going to do all that for you. And so how do we go around doing the procedure? So usually what is done is that a burhole or twistle is done at a pre-coronal entry point as decided by the stereotactic system. The important thing is use the imaging to avoid veins, the sulcus, and the ventricles. So how you would do a navigation guided biopsy, for example. So it's the same concepts apply here. After the burhole of the twistle, the dura and the pia has to be opened. And when you're doing that, it is important to avoid air entry. And the reason for that is to avoid brain shift. Because once brain shift happens, your entire system is rendered useless. So to do that, you have to continuously irrigate the field to make sure no air goes inside. And you can use fibrin glue also to prevent air entry. Once the dura and the pia are opened, a macroelectrode can be directly introduced for stimulation, or you can introduce a cannula through which both a microelectrode recording system and a macroelectrode stimulation system can be introduced. Right. So what is this system that we're talking about? What is the stimulation and what is microelectrode recording? So macroelectrode stimulation and microelectrode recordings can happen within the same system as is seen over here. So this system is basically, it is one lead which is capable of both microelectrode recording and macroelectrode stimulation. So this has two parts here. As you can see, this is a stimulation electrode and this is the recording electrode. So this part, which is inside the stimulation electrode, can actually be pushed out and pulled back in. Right. So when you're doing the microelectrode recording, this recording electrode is pushed out and it can measure at the target your MER recordings, and then it can be pulled back out, and then you can use the stimulation electrode and push that deeper to stimulate the target. Now, macroelectrode stimulation alone, it is a faster process and it does not require as much effort as doing MERs. Okay, it is less intricate and it creates a map of responses to stimulation, which you can use to guide as to where your sensory motor areas of GPR STN may be. But because the lead is much bigger, there is a lesser resolution than MER provides. Microelectrode recording, on the other hand, it is able to map activity at the level of individual neurons. So it provides a more detailed resolution. It can even pick up the pathologic oscillations that we discussed in the previous seminar that are the primary pathology responsible for PD. So it can even go to the STN or the GPI and pick up these pathologic oscillations. The important thing with MER is that it is more time consuming and it requires more intricate equipment and higher levels of expertise. So in some places, they just do macro-related stimulation and proceed with ablation or DBS. But in a lot of places, microelectrode recording and macroelectrode stimulation are done together, and following that only, DBS or ablation is done because it is more accurate to get both MER and stimulation. Right. So once the burr hole or the twist drill is made and the lead is inserted, there is the MER or the macroelectrode stimulation which is done, followed by the lesioning. So in cases of GPI, it is important to use the mapping systems of stimulation and MERs to identify the sensory motor region of the GPI. Apart from that, the other areas we're trying to identify is the optic tract and the internal capsule because we do not want to target these. Now, as we have discussed multiple times, the sensory motor region of the GPI is going to be in the posterior ventral lateral region of the GPI. So anatomically, we need to go and target this particular area of GPI. Once you reach there anatomically, that means either using navigation or using your stereotactic guidance system. Once you get there, we're going to do microelectrode stimulation, microelectrode recording followed by macroelectrode stimulation. So as we can see here, based on anatomic guidance, you can insert the electrode into particular areas of the GPI. As we can see, the close by areas that we want to avoid would be the GPE, the internal capsule, and the optic tract. Okay, and when we're entering, we're going to end up going through the striatum, the GPE, and then finally reach the GPI. So on the right-hand side, you can see what are the microelectrode recording waves that we get at different areas in the striatum, in the GPE, at the border between the GPE and the GPI. And when you finally enter the GPI, this is the microelectrode recordings that you should pick up. So this will help you identify that you've entered the GPI. Now, there are multiple steps that are done to ensure that we do not end up missing what we're targeting. So first, when we do enter the GPI or first the GPE before we enter the GPI, we're going to end up stimulating to check for what is the response. We're going to check the patient, look for motor and visual symptoms, and then we're going to create a test lesion at 42 degrees Celsius. We'll discuss this as to why 42 degrees Celsius, followed by first creating a temporary lesion at 60 degrees Celsius, and then a permanent lesion at 75 to 80 degrees Celsius. The entire time we're going to monitor the patient for changes in motor strength, as well as vision and speech. If there are any problems observed, we will retract the electrode 2 millimeters and try again. Right, so similar concepts apply even for STN lesioning. Again, we are going to target the sensory motor region of the STN, just like as we were doing with the GPI. So here, the sensory motor region of the STN is also located dorsolaterally only. But it is important to remember that around the STN, there are 4 important structures that we should miss when we're targeting the STN. We should avoid the corticospinal, the corticobulbar tracts, the third nerve nucleus, and the lemniscus. Right. So depending on where the lead may be, if it's anterolateral, you might actually end up getting a motor response, which means that you're quite close to the corticospinal tract and possibly need to move the direction of your lead to enter the STN properly. So similarly, if you get conjugate eye deviation, you might be in the corticobulbar tract. If you get a medial forced eye deviation, you might be in the third nerve nucleus. And if you get a sensory response, you might be in the lemniscus. So this stimulation allows you to pick up in relation to the STN where you might be and then reposition the lead accordingly. Right. So similarly, we do a physiological mapping of the VIM thalamus nucleus also. And when we stimulate there, it produces an upper extremity tremor arrest. So we're able to identify that we are in the VIM thalamus and not elsewhere. So as we discussed, once we have identified that we are in the target we wish to ablate, we provide a test lesion. This is done at 42 degrees Celsius with the radio frequency ablation probe for 60 seconds. This is because temperatures which are below 43 degrees Celsius will not produce any permanent lesions, but they will produce some temporary lesions. So we are able to check for adverse effects with this temperature. After that, we will first produce a lesion at 60 degrees Celsius initially. And once we are sure that there is no side effects, we can produce a lesion at 85 degrees Celsius for 60 seconds. Right. So with ablation, what are the benefits and the complications that may arise? So with the paladotomy, it has been found that the most prominent effect, as we have discussed, is control of dyskinesias. There's a 70% decrease in contralateral dyskinesias, but there is also a 30% decrease in the ipsilateral dyskinesias. Again, remember, ablation is done only on one side, right? It's not done bilaterally. Apart from that, there's also a 30% decrease in the off time. So it is improving your on off phenomena and decreasing the off time of medications. It also reduces tremors and dyskinesias, which has quite a sustained effect, but the benefit on rigidity and bradykinesia is slightly less sustained. But overall, it works quite well for the cardinal features of PD, at least three of them, that is tremor, rigidity, and bradykinesia. It also works very well for dyskinesias. But it does have some side effects. Verbal fluency can decrease after a left-sided paladotomy, and a left-sided paladotomy can also lead to some frontal lobe dysfunction. Apart from that, there are also risks of the surgical technique itself. There's a 4% risk of hemorrhage and infarct. There can also be changes in speech, which are the most common side effects of a paladotomy. There can be dysarthria, hypophonia, or dysphasia. There can also be alterations in cognition, personality, and behavior. On a very rare and probably not very important complication to remember is something called Pisa syndrome. So with a paladotomy, a very rare late stage phenomenon that may occur is a lateral flexion of the neck. On the other hand, the thalamotomy, as we know, it only works to reduce tremor. So the greatest benefit is in patients who have an asymmetrical tremor. Just like with GPI or STN ablation, there's a risk of hemorrhage. But because it's in the thalamus, there are other risks of involving the motor and the sensory fibers, and you do some bulbar symptoms as well. With a subthalamotomy, again, the benefits are it will reduce tremor, it will reduce bradykinesia and rigidity, just like GPI will. There is going to be some ipsilateral relief as well. Again, remember, most of ablation is going to be is going to be unilateral and not bilateral. Also, as we have discussed multiple times, it is going to reduce medication needs, which GPI will not. But unlike what GPI does, it can induce dyskinesias. So GPI ablation is going to reduce dyskinesias, but it is possible that STN ablation can actually induce dyskinesias. But most of these are mild and transient. Right, so a few questions about this section. Which of the following is true? Subthalamic nucleotomy reduces on-state dyskinesias. FDG PET would demonstrate a lentiform hypometabolism in Parkinson disease. MERs are the most accurate and quickest method to perform target localization. The sensory motor area of GPI is located in the posteroventral lateral region. Yeah, so the answer is 4. It is the sensory motor area of the GPS located in the posteroventral lateral region. So subthalamic nucleotomy will not reduce on-state dyskinesias. There is the potential for it to actually induce dyskinesias. FDG PET would demonstrate hypermetabolism in the lentiform in TD and hypermetabolism in Parkinson plus disorders. MERs are an accurate method to perform target localization, but they take time. They're definitely not the quickest. Right. So which of the following complications of ablative surgery are incorrect? Targeting the GPI can cause potential blindness. Targeting the STN can cause potential hemiparesis. Targeting the VIM thalamus can cause potential hemianesthesias. And targeting the STN can cause Pisa syndrome. Right, so this question is slightly complicated. So first we'll discuss the obvious options. Targeting the STN can definitely cause potential hemiparesis because the corticospinal and corticobulbar tract are quite nearby. Targeting the Wim thalamus can definitely cause potential hemianesthesia because the sensory tracts are nearby. Targeting the STN definitely does not cause Pisa syndrome because it is a complication of targeting the GPI. But targeting the GPI, can it cause potential blindness? The thing is, targeting the GPI can affect the optic tract, which can cause visual field deficits. So it could be considered as potential blindness, but it does not actually cause a reduction of visual acuity. But the answer for this question would be STN and Pisa syndrome, because that is caused by GPI targeting. Right, coming to the last topic for today, that is DBS for Parkinson disease. So we have already covered a lot of how DBS is done with the procedure done for ablation. It's quite similar, except instead of ablating, you're going to be stimulating the nucleus. Right. So with DBS for PD, the main reasons that we have discussed in the last seminar, there are two main reasons to consider DBS for PD. One is tremor, which is refractory to medications, and the second is motor fluctuations or on-off phenomena arising from the use of dopamine. Now, the following symptoms have been found to improve following DBS. Okay, so there's three important symptoms. That is tremor, rigidity, and also bradykinesia. Apart from that, dyskinesias can improve following GPI DBS. Motor fluctuations will improve, as we and off-period gait freezing will improve. And as we have discussed, classic idiopathic PD will improve. But atypical Parkinsonism will not improve. On-period gait freezing will not improve. So on-period gait freezing usually happens because of dopamine-induced effects, and that is why this will not improve with DBS. Apart from that, autonomic function, cognition, hypophonia, postural instability, and mood disorders will not improve following DBS. Right. So as we've discussed, there are two important targets when it comes to DBS, the STN and the GPI. So there are reasons to choose one or the other. More commonly, STN DBS is being chosen these days, but there are reasons when you would want to choose GPI. So as you've seen, if you use STN, overall it will reduce levodopa requirements over time. It is easier to target surgically the STN rather than GPI. We will see soon as to why. But targeting the STN can also cause some weight gain. But because for STN you require a lower level of stimulation, there is a longer battery life with STN as compared to GPI. Now, the advantages of using GPI is that there might be a lower chance of cognitive decline with GPI. So patients who already do have some cognitive decline might benefit from a GPI DBS as compared to an STN DBS. It is easier to program postoperatively GPI DBS than STN DBS. It has been found that they maintain letter verbal fluency with GPI rather than STN, and they have more mood stability with GPI rather than STN DBS. STN DBS also does have some problems of higher risk for mood and cognition decline, an increase in impulsive behavior and errors in judgment, and it can also worsen swallowing. So as we can see, there are reasons why you would choose STN and there are reasons why you would choose GPI. Right. So how do we go about performing DBS? So it is quite similar to how we perform ablation, as we have already discussed. There is anatomic and physiologic targeting which is done to target these nuclei. Anatomic target is with stereotactic localization, which can happen with using a stereotactic frame or even frameless these days. Physiologically is with MERs and with stimulation. As we know, MERs will increase intraoperative time, but they can also be problematic in certain populations because they increase the time and the patient needs to be awake. That can cause problems in some anxious patients, patients with advanced age, and patients have severe off-period pain. So in these patients, you might want to consider something known as asleep DBS. So here, because of a lot of recent advances, there have been some improvements in anatomic localization itself. So we might not need physiologic localization per se. So these advances include skull-mounted aiming systems, which definitely improve accuracy of anatomic targeting, even frameless stereotaxy, and intraoperative MRI or CT. So now, recently, the question has come as to whether we should use awake versus asleep DBS. So it has been found with studies that accuracy of placement and complication profile is similar with awake versus asleep DBS. There is a clear-cut advantage of awake, though, that you are able to directly intraoperatively assess whether the patient's symptoms have reduced or not. But in patients who are older and who have significant tremor, anxiety, and major off-medication disability, it might be more prudent to consider a sleep DBS as compared to a wake DBS. Right. So all patients who are being considered for DBS have to undergo an MRI, and these three sequences are the most important. So they would undergo a gadolinium enhanced volumetric 3D T1 sequence, usually an empirich T1, and two 2D sequences, which are both T2 sequences, an FSCIR and a T2 FSC. So an FSCIR is basically a fast spin echo inversion recovery sequence, and that is for targeting the GPI. And the 2D T2 FSC, on the other hand, is a fast spin echo sequence for targeting the STN. So how is this surgery performed? Basically, you're going to have the patient awake, apply a Lexer head frame on them, and get a CT scan. Following which, you're going to take the CT scan, put it in the computer, and the computer will fuse the CT scan with the preoperative MRI. And then whatever fiducial markers exist on the Lexel head frame, it is going to register that with the CT and the MRI. Once it does that, it is going to reformat the image sets and produce images that are going to be orthogonal to the mid-commissural plane. Right. So once we get those images, we can get coordinates to target the STN on the GPI or whatever nucleus we're targeting. So when it comes to STN, the numbers to remember are 3, 4, and 12. And when it comes to GPI, the numbers to remember are 2, 5, and 21. Okay, again, nothing to memorize. If you're able to remember, good. If not, it's fine. But it's quite easy, 3, 4, and 12. Right, so it is STN is 3 millimeter posterior, 4 millimeter inferior, and 12 millimeter lateral to the mid-commissural point. So once you have that value, you're going to come to this axial section that is going to be 4 millimeter inferior to the mid-commissural point. And at that point, you'll be able to visualize a red nucleus. A tangent which is drawn anterior to the anterior border of the red nucleus is going to pass through the STN at this point. Okay, so our target is going to be 2 millimeter lateral to the point at which this line crosses the medial border of the STN. So this is our target at the STN. When it comes to GPI, the numbers to remember on the other hand are 2, 5, and 21. So as we know, instead of posterior, it is going to be anterior. It is going to be 5 millimeter inferior and 21 millimeter lateral to the MCP. Once you have that axial section, you're going to measure the pallidocapsular border. That's a border between the GPI over here and the internal capsule. And you're going to divide this border into posterior 1/3 and anterior 2/3. A line which is drawn perpendicular to this for a distance of 3 to 4 millimeters is going to pick out the target over here. So that is the target for the GPI. Right. So from these targets, you're going to draw lines reaching the skin at these particular angles, about 0 to 15 degrees from the vertical in the coronal plane and about 60 degrees from the ACPC line in the sagittal plane. So this is going to tell you at what point you should enter from the skin. Right. So once you have made the burr hole, you've introduced your leads. In the awake surgical technique, we're going to be doing microelectrode recordings and microelectrode stimulation. So with MERs, how would you pick out whether you are in the STN or not? So with MERs, once you enter, the recordings will usually begin 10 millimeter dorsal to the target. When you enter the STN, the neuronal action potentials will be occurring at 20 to 50 hertz firing rates, as you can see over here. So as you can see, it is quite different from what you would have at a higher level of dorsal thalamus. So once you enter the STN, you should get 20 to 50 hertz firing rates. At the inferior border of the STN, there will be a sudden decrease in whatever background noise is there. And if you continue going below that, you're going to enter the substantia nigra pars reticulator, and that is going to be showing a much higher signal discharge of 50 to 70 hertz. So you'll be able to identify that you've entered the SNR and you're not in the STN anymore. So similarly for GPI, again, you can use MER to identify that you're in the GPI. But unlike the STN, the GPI is going to have a much higher firing rate. So you would begin recording 50 millimeter dorsal to the target. In the striatum, the discharges would only be 0 to 10 hertz. Once you enter the GPI, the discharges will become 30 to 60 hertz. And once you enter the the GPE will be 30 to 60 hertz. And once you enter the GPI, the firing rate becomes much, much higher with 60 to 100 hertz of firing rate. Right. So once you have used the microelectrode recording, you identify that you're in the sensory motor region of the GPI or the STN. Following by for this would be followed by microstimulation on the other hand. So you would retract the MER electrode and then advance the macrostimulation electrode to stimulate the target. So with the GPI, the stimulation lead would be placed with the bottom of the distal contact at the MER ventral limit of the target for the GPI. So again, just you retract the microelectrode and then push the macroelectrode such that it reaches the ventral limit of your MER GPI readings. For STN, the lead should be positioned in the middle of the dorsal STN. Following that, stimulation will be done at 180 hertz. And if you are looking for adverse effects, you have to stimulate at least to 4 to 6 milliamperes or 6 to 10 volt range to look for side effects before you can conclude that there are no side effects and you're in the right target. So the usual side effects you're looking for are that once you stimulate, there should be some diminution of contralateral arm rigidity. So it is the most readily detectable effect that you are in the right location. Now, sometimes the motor symptoms may actually improve without stimulation also, and that can happen just because of passing of the electrode through the nucleus. And that is known as a microlesioning or the stun effect. So in that cases, macrostimulation actually would create no potential changes because already that area has been stunned. Right. So with DBS, what are the results? A 2005 study has found that with bilateral ST and DBS, there was a 48% improvement in UPDRS3 score as compared to GPI, which showed a 39% improvement. But the study found that this difference was not significant. Another trial found a 34% improvement with STN as compared to 30% with GPI. And a randomized study found a 29.9% improvement with STN as compared to 26.6% improvement with GPI. So overall, almost all studies have demonstrated that improvements in UPDRS3 scores are higher with STN as compared to GPI. That is why STN is more frequently used these days as compared to GPI. Long-term studies have shown that DBS is safe and effective over long term, but the non-motor symptoms do continue to progress with DBS. So ultimately, patients are going to continue to have problems. There are also sometimes complications that can arise with DPS. The major complications do include hemorrhage, and there's a higher risk of hemorrhage for patients who have hypertension, and if you use the microelectrode recording leads. There's also a 10% risk of infection, and the hardware might fail. Later on, over time, there can be hardware erosion, lead fracture, or lead migration. Right, so a few questions about this section. So which of the following may not improve following DBS for PD? Bradykinesias, dyskinesias, off-period gate freezing, or on-period gate freezing? Yes, so on-period gate freezing will not improve following DBS or PD. The other three will improve following DBS or PD. Now, which of the following MRI sequences is ideal for parallel targeting? Empiric T1, FSC-IR, T2 FSC, or T2 flare? So the answer is FSC-IR. Empiric T1 is required overall for anatomic localization. FSC-IR is required for targeting the GPI. T2 FSC is required for targeting the STN. And we do not use T2 flare in DBS.